The first premolar tooth is carried out with number 2 surgical length round burr. Using a light touch, the burr sculpts away tooth structure, brushing buccal to lingual, as it is carried in an apical direction until the pulpal roof is penetrated. The root lies slightly lingual to the clinical crown, so the access cavity is angled accordingly. The Explorer checks for straight line access, and its angle of entry helps the clinician further refine and align the occlusal opening with the underlying root canal system. At high magnification, you can see the isthmus and the ovoid nature of the orifice. The Explorer is frequently placed in the tooth to establish the straightest path possible into the root canal space. Access refinements are made with the round burr and the diamond. This cross-section demonstrates the importance of completely removing the pulpal roof. This unsupported dentin is eliminated with tapered diamonds, so straight-line access cavities are achieved. The Explorer checks for straight-line access by sliding down smooth axial walls. High magnification verifies excellent funneling into the underlying root canal system. This cross-sectional view demonstrates the Explorer gliding down the axial walls and probing the most buccal and lingual extent of the narrow, ribbon-shaped orifice. Complete access is a critical element of successful endodontics. The access cavity in the mandibular first molar is performed with a number 4 surgical length round burr. The burr is swept mesial to distal, buccal to lingual, as it is carried in an apical direction until the pulpal roof is penetrated. Looking coronal, we get a special effects view of the burr falling into the chamber. The microscope affords high magnification, and we can begin to appreciate the floor anatomy. The Explorer traces the outline form and demonstrates the access cavity needs to be expanded to establish a better path to the orifices. A tapered diamond burr is excellent for expanding the access cavity and establishing divergent axial walls from the pulpal floor to the occlusal cavo surface. Expanded access cavities create a great pathway to the orifices. Coronal restrictive tooth structure is eliminated, allowing files to pass freely into orifices, facilitating cleaning and shaping. At high magnification, the completed access cavity has smooth, divergent axial walls, allowing files to slide easily and unimpeded into orifices. Expect 50% of all mandibular first molars to have 4 systems. The most frequently missed system is the distolingual, emphasizing that access cavities must be completely de-roofed and are often rectangular in outline form. Carefully probe the isthmus between the MB and ML orifices, as occasionally an extra orifice will be identified. Methods of locating calcified canals, extra canals, and specifically the MB2 of maxillary first molars starts with philosophically believing it's there. In this particular access cavity, the major limitation would be it's underprepared and limits the operator from finding the extra canal. To facilitate finding extra canals, a Designs for Vision surgical operating headlamp beams a column of light coaxial with the line of vision. Headlamps are an excellent method to beam light into access cavities. This finalized outline pattern is representative of an ideal access cavity. Compare this underprepared access with the outlined expanded preparation and appreciate how endodontic treatment will be simplified. A Spartan piezoelectric ultrasonic handpiece is used that receives a variety of specially designed tips. These tips are energized, and with light pressure they can easily remove calcific tissue, pulverize stones, and importantly, remove the shelf of secondary dentin and calcific hard tissue that overlies hidden orifices. A dental Explorer continuously checks for extra canals, straight line access, and calcific material. Designs for Vision also distributes a variety of magnification glasses. Magnification is a powerful method to greatly enhance your vision into pulp chambers. Global Surgical Corporation distributes the remarkable Urban microscope. This microscope is extraordinary and serves to phenomenally increase vision through lighting and magnification into the pulp chambers of teeth. The clinician can confidently remove stones, calcific material, and have confidence in making the distinction between pulpal stones and floor anatomy. Quality Aspirators distributes fiber optic wands that can be utilized for transilluminating teeth. Light is beamed buccal to lingual at the cervical area of the teeth. Additionally, certain endodontic clamps have receptacles to receive fiber optic lights that, when activated, transilluminate through the tooth, giving more vision into the pulp chambers. Pulp stones are gently teased out of the pulp chamber with a dental explorer. Stones should not be pushed inadvertently deeper into the canal, where they can block and frustrate the clinician's ability to clean and shape. Firm explorer pressure is a critical concept for identifying the MB2. The fingers will blanch as we vigorously use the explorer to punch through secondary dentin and calcific material. Tapered diamond burrs peel back the access cavity towards the mesial at the expense of the mesial marginal ridge and the mesiobuccal cusp, affording better straight-line access into the MB canals. The explorer is utilized to probe for the position of the MB2 orifice. The access cavity can be irrigated with methylene blue, then flushed out and dried. Organic tissue, isthmus areas and orifices will absorb methylene blue, and the stained areas can serve as a roadmap for identification of anatomy and fractures. Occlusal adjustment is critical as it makes the distance between the occlusal table to the pulpal floor shorter, bringing the clinician closer to the action. This enhances visibility and allows the clinician to work with more confidence. The expanded access cavity then begins to take shape, and the isthmus between the MB1 and MB2 can be seen. The explorer is utilized again to excavate and remove calcific tissue. In a reverse angle at high magnification, you can clearly see the MB1 and MB2 orifices. Gauge-Glidden burrs brush cut from the orifice towards the occlusal table, giving a straighter pathway into root canal systems. To improve access, Gates-Gliddens are arced away from focal danger at the expense of the mesiobuccal axial wall. Irrigating pulp chambers will allow irrigant to react with organic tissue. This reaction liberates oxygen, and bubbles will rise to the occlusal table and assist in identification of extra systems. The completed access cavity has sufficient space so the clinician can perform excellent endodontics. You can see, when we were underprepared, there was no opportunity to address the anatomy in the underlying root canal system. The explorer is passed down the axial walls in a straight-line manner from the occlusal table to the respective orifices. Access is the first critically essential objective of endodontic treatment. In Tape 2, we will work through this space and explore exciting new strategies and techniques to clean, shape and pack root canal systems in 4 dimensions.